So basically, when I'm in a presentation, then this is the stage where I stop and I tell my audience that I wish that I had one research to show them. And this research would be about 500 cases in patients who all had a periapical lesion, which means an infection in their periapical area that is visible in X-ray. And then 2 years later, I could show them that everybody is healed, and the SDF gets an amazing success rate. Unfortunately, this kind of research is very difficult / impossible to do, since you have all those variants, all those independent variants that you are. It's very difficult to control. You need a lot of patients. You need all of them to, most of them at least, to come back to the second and third visits to check up on them a year later. And you need to make sure everybody gets good crowns. Okay, you need to allocate those patients who have a visible lesion on X-ray, and there are just too many variables. And actually, no other company, including Dentsply or no one, not even one of the giants, has this kind of research. Not to mention how much it's going to cost, and then not just the technical aspect, but also the financial aspect. So what we decided here in Redent, we knew that we are presenting a very innovative, very new technology, and we do have to prove ourselves. It's not that it's not the same as another company who just have a slightly different file and just has to prove that it works a little bit faster / doesn't break as much / does one thing a little bit better than, keeps the curvature of the canal a little bit better than the other files. We decided that instead of doing this impossible research, we will take every field inside subfield in endodontics, all the factors that actually contribute to good endodontic treatment, and we will check them one at a time and prove that in each factor, that each factor in endodontic treatment we do much better. So if it walks like a duck and talks like a duck, it must be a duck.
Mm-hmm.
So that's why the evidence-based endodontics, and we as a company have the, I think the largest. Certainly, if you look at it in the 2 years since the first one has been published, since 2010. I think the first one is from 2010. So in the 2 years that have passed, we have, in this presentation it says over 15. We're looking at about 20 articles, many of them in the Journal of Endo and the International Endodontic Journal, which are the two main journals in endodontics. Now, the way I divided those was from what I think is most important. I started with what I think is most important, and this is the thing that every medical student, every dental medical student learns in the first class, and that's premium non-nostril. First, do no harm. Okay, so you have the patients come to you, and the first thing you have to do is don't leave the patient at a worse position than what he was before coming to you. And this takes me straight to the microcracks article. Okay, we can see in this article from Turkey, who was published at the Journal of Endo, a Turkish group. They actually tested 1, 2, 3, 4, 5, 6, 7 groups, if you include the control group. Tested 7 groups, and the control groups and hand file groups showed no microcracks after preparation, immediately after preparation, and the SAF was the only mechanical file that showed no microcracks, 0 microcracks after mechanical preparation. Now, when I talk about microcracks, a lot of the attendees in the lectures, they think, oh, how micro is microcrack? Do you need an electron microscope to see it? Well, no, it's not that small. Actually, if we're looking at these pictures from the article, this is a slice to the tooth. I would say this is a magnification of about a 20-fold. Okay, probably maybe even less than a 20-fold. And you can clearly see here, the micro cracks, okay?
Right.
That was caused. Now, a lot of dentists will tell you, well, this is an artifact. This is because the tooth went dry, or the slicing of the tooth, the process of slicing was traumatic to the tooth, and you got cracked. Well, how do you explain that? My answer to them is, how do you explain that the control group and the hand file group did not show any micro cracks? They underwent the same slicing and the same process as the other groups. Another thing I want to show you here, and this is something I showed in illustration in micro CT, but this is live. You can see how the rotary file drilled a rotary pore in the tooth.
Right.
And you can see all this area. This is full of tissue, potentially contaminated with bacteria.
That's the isthmus? Or?
So this was that's the isthmus, yes, exactly.
Yep. Okay.
That's the isthmus. Okay, what happens in this kind of teeth, this is the mesial roots of lower molars, okay? And mesial roots of lower molars. And what happens in this kind of teeth is that you can, they start off, when the patient is young, they start off as one wide canal, okay? This is how it starts.
Mm-hmm.
And in time, this part gets narrower and narrower and narrower, okay, until in old age it might even close down completely, leaving the patient with two canals. So if you have a young patient, this might be very much open. This is another one. This is the ProTaper, and although ProTaper did not show as many, it didn't show the most fractures in this research, the most amount of fractures, but it did show one complete fracture. This is not a micro crack. This is a complete fracture. This tooth is, as for now, this tooth is irrestorable. You have to extract it. While in micro cracks, if you're looking at micro cracks, then the tooth can still be restored, and there are no symptoms until the micro crack becomes a full-blown crack. Now, this gives us a hint of how this kind of root canals really should look like. This is the SAF. First thing you see this, there are no micro cracks in the dentin here.
Mm-hmm.
The second thing you see is that it kept the teardrop shape of this canal.
Right, I like that.
Okay, so that's excellent. This is very small. Everything here, you see here a 20-fold magnification, but this is probably less than 1 millimeter of dentin.
Okay. Okay.
And this tooth after treatment has to undergo an obturation process, which is traumatic to the tooth. Okay, it involves applying more pressure. Actually, there are some articles that show that after the obturation you get even more micro cracks and full cracks. Okay, and this tooth has to be in the mouth for years. Okay, for years and years, and survive in the mouth. So the more dentin you leave here, the better. Another thing we discussed in our previous meeting was the packing of debris into those isthmus areas. Okay, and I showed you the research of Frank Paquet, and I showed you how he saw on micro CT where the debris are getting packed. Now this is, I think this is amazing footage. These are slices from micro CT. Okay, and you can see here the tooth before treatment, and you can see that it has the same kind of teardrop shape canal with an isthmus in the middle. Okay, so this is probably again a mandibular molar with mesial roots of a mandibular molar, and you can see the same tooth here. Okay, the same kind of root canal here, and treated with the rotary file. You can see a round preparation, and you can see here some I would call it clouding. Okay, so it's gray material here. Okay, round preparation with gray material packed in here. And what Frank Paquet discovered in his research was that 10% of the root canal isthmus was packed with debris. He later on tried to reduce that 10% by using EDTA. EDTA is a what we call a chelating irrigant. It takes calcium and dissolves it. Okay, so if you have some leftover calcium, which is dentin, is made of mainly of calcium. If you have leftover dentin, we put EDTA. We want to dissolve it. So the EDTA managed to reduce from 10.1% debris to 7.9%. Okay, and again, when we're discussing bacteria, someone might think, 10% is not that much. But when we're discussing bacteria, all you need is a minimum amount of bacteria that live in a relatively protected place, and a few days, a few weeks, a few months later, you have millions of bacteria instead of that minimal amount.
Mm-hmm.
Okay? So this is what is left over in the root canal after the best treatment you can possibly give with rotary file. If you're looking at the SAF file, the same kind of root canal, okay, we're talking about a tenfold decrease. This is a 1.7%, and if you use EDTA, you get a little bit more, a little bit less, you get 1.3% debris. So this is another thing that I don't want to do to my patient. My patient came to me with an open isthmus, okay, what he might have had is maybe it had some contaminated tissue there, and I'm leaving him with packed dentin chips that are completely blocking this isthmus area and leaving the bacteria to grow, to thrive.
Okay.
Okay. And the final thing I want to talk about in this do no harm is the file separation phenomenon. You'll see a lot of dentists that did not even change from pen files to rotary files, and the main reason for that would be the lack of control. You cannot feel when the rotary file is going to break. Okay, rotary files are made out of nitide. Rotary files are made out of nitide, and nitide is an excellent metal, but it does not give you any warning signs. Okay, it doesn't look like it got any wear. It looks like brand new until it breaks. Okay, because it accumulates microcracks inside the core of the file. So with the SAF, it's made out of the same nitide, so it's not the material that is different, but the design of the SAF, if we take a closer look, you can see that it's like I would say it's like a boat or a submarine where you have compartments. Okay, so the damage is localized. Okay, and you can have breakage, but this breakage will be localized, and this piece will be kept attached to the file by its other end. Okay, another way of breakage is this. Okay. And you can see here one of the arches actually broke off, but it remained attached to the file. Now this is a very different picture from rotary files, from drills breaking, because when a rotary file breaks, it usually does so in the most apical part, because this is where the rotary file is very thin. Okay, it will get screwed in the canal,
right,
stuck there, and then break off. So you have a little piece blocking your canal, okay, blocking your root canal. So you cannot prepare it, you cannot irrigate it, okay, you cannot rinse it because it's blocking the canal. And if it's stuck there forcefully, it's jammed in. So taking it out is a very violent process that might actually damage the tooth more than it will help her. So in many cases, you just leave the piece there, okay, and you hope for the best. You hope for the best. You hope that you manage to disinfect it enough so it will not re-inflame soon. So this and breaking a file for the dentist is a traumatic experience. They hate it. you'll hear, if you hear them talking about it, it's something that can ruin your day. Okay, it's irretrievable almost, and it's something that you know that you did wrong for your patient.
Do they remove the file? Do they try to remove the file?
Sometimes, if it's a very thin file, they will try to remove it. If it's in a straight canal and not a curved canal, there are a lot of factors. Most of them will, if they cannot remove it easily, most of them will tend to leave it there, and you're obligated by law to tell the patient. Okay, you have to explain to him that you left a piece in his root canal, and what you also have to do is that once you did that and you're uncertain whether your treatment is successful or not, you cannot put the crown on this tooth. Okay, you're not doing anything irreversible. You're not gluing a permanent crown to a tooth that you don't know if you cleaned it enough or not. So what they would do, they would put a temporary crown and send the patient off for periods of up to a year sometimes. Okay, and that's money lost, because not only the patient has to come back again, they don't always come back. Why would you want to come back to somebody who just told you he broke an instrument in your tooth? Right. Why wouldn't you go back to somebody else? Okay, so patient that is leaving your, it's breaking the sequence of the treatment. You never know if you're coming back, if it's coming back in a year or not. Okay, so dentists really look at this as an upside of the SAF, because here what you have is a let's say a financial discomfort, because the file does cost money, but then again, you broke it. You can feel that, you can see it. You take it out, you throw it away, you put a new file in, and everything is as good as new. So, okay, and this is actually something I changed a little bit. I will talk about it a little bit later, okay? I changed something in the presentation, and this is about the minimally invasive nature of our treatment, okay? And if you just remember that scalpel versus an endoscope, and think about appendicitis, okay? But we'll come back to that a little later, because I have another slide that really demonstrates that what is minimally invasive treatment for me. So we talked about this article by Frank Paquet about the micro-CT and the untreated root canal surface. Okay, we went to Frank Paquet and we offered him to do the same kind of experiment using the SAF. That was in 2011 when it was published. And he did the same experiment with the same equipment, with the same kind of teeth. And what he got here, instead of 40 to 50, let's say 45 to 50% of the canal wall untouched, he got closer to 20, 23% of the canal walls untouched. So that's not a perfect result, but if you see what those canals look like, you would know that there's no such thing as perfect results, but you can, but this is definitely much closer to what the dentist has in mind, what he thinks he's doing when he's doing a root canal treatment. Okay, nobody thinks he's not touching half of the wall.
Right.
And if you look at the, I showed this research also before, about the same experiment about untouched, untreated root canal surface in distal canals of lower molars, distal canals of lower molars, which happen to be usually very flat. Okay, so these are the numbers that they could achieve by different techniques using a hand file and ProTaper, and this is what the SAF was able to do. Again, it's not perfect. It's not perfect, but it is still much closer to what the dentist has in mind when he's doing this treatment. I don't know if this is going to work. Let's see the video. This is actually micro-CT. You know, we'll skip that. You can watch it on your computer. Okay. This was a micro-CT of a video micro-CT that I did of a flat canal, where the red is the pulp before treatment, and the blue is the is the it's not a pulp, it's the cavity, the preparation cavity after treatment. And you can see how it really engulfs all the red area, almost all the red area, without leaving too much of it untreated. This is where you can really see the untreated area and the treated area. So this is from a researcher called Gustavo de Deus. He's a Brazilian researcher. He's very good in the art. It's an art of histology. Okay. What they do here, I will just explain a little bit. They take a tooth, a regular tooth. Okay. You do whatever you want with it. You treat it. You do the root canal treatment. After you did that, you put it in the I've mentioned before the chelating irrigant, the one that dissolves calcium.
Mm-hmm.
And what it does, if you know the experiment about how do you put a tooth in a Coca-Cola cup, and it actually softens the tooth. The reason that it softens the tooth is that the Coca-Cola is acidic, and it dissolves the calcium ions from the tooth, and all that's left is the collagen matrix. Okay, the tooth is actually built from a collagen matrix, and inside this matrix there's hard calcium. So if you remove the calcium, all that's left is like a rubber, kind of a rubber substance made out of collagen. So after he did that, he's able to shave really thin slices from that tooth, and take those thin slices and put all sorts of chemicals on them to highlight different things. And this one is a hematoxylin dye that actually dyes organic tissue. Okay, so of course you can see the light pinkish area, which has the collagen matrix. Okay, this used to be the root canal, so obviously it's empty. There's nothing in it. This is the deep purple is where you had a lot of organic tissue, and that's the pulp, actually nerve tissue and blood vessels. You can see here. Okay.
Right.
And on the wall, if you can see the purplish area right here, this is something called predentin. Now, I can only describe it as a thin crust, not a crust, membrane. A thin membrane that is coating the original canal. So you cannot see it here, okay, but you can definitely see it here. Okay, see this irregularity. So this is also this is a more, I wouldn't say primitive, but an older way of viewing and looking at the root canal and see where our files mechanically, not just mechanically, so which of the organic tissue was removed and which was not. So we can see here, this is obviously, you should know by now, this is a rotary file because we see the keyhole appearance. Okay, and this is where the rotary file went in. Mm-hmm. And this is the border where the irrigation went in. Okay, so we got the rotary file went in here, and the irrigation went in a little bit more, okay, half this way, but there was not enough irrigation. What you have to remember is that dentists use sodium hypochlorite, which is bleach. Bleach is not good as a bacterial killer. It's not just a disinfectant. It also has the ability to actually dissolve tissue. So we have two irrigants. You're learning endodontics here as we speak. We have two main irrigants in endodontics. One of them is EDTA, which dissolves calcium, okay, and the other one is sodium hypochlorite, which also dissolves tissue. So using the two, you are able to get a chemomechanical preparation, and they help you to dissolve the tissue and also remove some of the hard material. So in this case, the hypochlorite was unable to dissolve all the pulp, okay, and it was also unable to dissolve this predentin area. And this is the SAF in the same kind. Those canals were pair matched. Okay, he pair matched the canals before he started the experiment, and he made sure that he has pulp inside the root canal. Now you might think, how do you make sure you have pulp inside the root canal before you start treating them? And the secret is to actually, before you extract the tooth from the patient, you put a cold pallet against the tooth, and the patient feels it. It hurts him. It's cold. When you put something cold on the tooth, it hurts. So, and then this way you are sure that this tooth is alive prior to extraction. It's not a dead tooth, which means it has tissue inside. Okay? Those teeth were extracted due to periodontic reasons or other reasons other than endodontics. They did not require endodontic treatment in the patient. So this root canal was also filled with tissue, but the SAF was able to remove it and keep the original oval shape of the root canal. Now, when we cooperate with researchers, the only thing we ask them is to make sure to include oval root canals, oval-shaped root canals in their experiment, because this is where we really can show the difference between SAF and other files. Okay? So all our experiments are with oval root canals. Now I have another picture from the very same article in the brochure that I sent you. I think it's an 11-page brochure, and it clearly shows another case, another interesting case, where the SAF, there's this root canal which is this funny shape and a small protrusion. Okay, too small for the SAF to actually go in and clean it physically, but you can actually see that in this small protrusion there is no pre-dentin, and that the sodium hypochlorite was able to reach it and dissolve the pre-dentin. So this is another evidence for the good irrigation that we have with the SAF. And the irrigation, we have to describe it. Today there are mainly two kinds of irrigation. Some talk about positive pressure irrigation. Others talk about negative pressure irrigation, and I have to explain a little bit about that. I'll do my best. Let's start with the positive pressure irrigation. The oldest way of irrigating and cleaning and washing and rinsing the root canal is to take a syringe, okay, a regular syringe, put hypochlorite in the syringe, put the needle of the syringe inside the root canal and press and actually flush, we call it flushing, flush the root canal. And that sounds perfect, that sounds great. There are a few things that don't really work in that system. And one of them is what you call a vapor lock effect. If you take a very small tube, okay, and you close the bottom part of it, and you try to put a smaller tube from the upper part and rinse it, you will have an air bubble forming at the bottom part because the air doesn't have anywhere to go. So research has shown that wherever you put your needle in the root canal, your irrigation will only go to 1 millimeter deeper than your needle, okay? And the parts of the canal will be untouched, unwetted, I can say, by the irrigant because of the air bubble that is forming. So one might say, okay, what's the problem? We'll just take a longer needle and we will place it very close to the end of the tooth. We have to remember that at the end of this tooth there's a hole. Okay, there's a hole, there's the apical foramen. And this hole is a direct connection to the patient's bone and blood vessels, nervous system. Okay, direct connection. If I take a pin and I'll stick it through, it will end up in the patient's jaw, and it will just, from there it can go anywhere in the body. And the irrigant that we're using most of the time is sodium hypochlorite, which is very, very toxic to tissues. Okay, if you have a few drops of sodium hypochlorite flowing through the apical foramen, okay, flowing through the apical foramen out, you will have a very prominent response from the body. There's a better word for it, but I'll see if I can find it later. So you will see a picture of a patient with swollen face and bruised. He would look bruised. This is what we call a hypochlorite accident.
Okay.
Okay. If you look it up online, you can actually see that hypochlorite accident, and you can see pictures of that. And no dentist wants this to happen to him. So everybody is very afraid of putting the needle so close to the tip. What if I'm mistaken? What if the tip is actually half a millimeter closer to me than what I thought it was? Because, you know, mistakes happen. So what they would do, and this is what they teach you in school, you put the needle about halfway, and you kind of move it up and down in the canal to make sure it's not blocking the canal. Because if your needle is blocking the canal, okay, if you put a very thick needle and you stick it in the canal and you press, then the irrigant will have no place to go but down through the tooth, through the apical foramen. So this is positive pressure. Now, a company named Endovac invented the negative pressure irrigation. And what the negative pressure irrigation does is slightly different. You take, if you think of the tooth as a glass of wine, okay, a tall glass of wine, and the stem of the glass of wine, the leg, okay, tell me if something is not understandable. I'm aware of my limitations in English. So if you think of a glass of wine, and it has this leg where the glass of wine stands on, okay? And imagine that
the stem, we call it the stem.
The stem. Oh, okay. So I was right. The stem of the glass is actually hollow and connected to the glass. Okay. If you fill it up with wine, everything becomes red all the way to the bottom of the stem. Now, if I want to irrigate that safely at the bottom of the stem, according to the passive pressure, negative pressure irrigation, I would take a very thin and very long needle and place it at the bottom of the stem, okay, all the way down to where it touches the table. And then I will activate, I will hook it up to a suction machine, and I will start sucking, okay? I will activate the sucking, and then I will take my bottle of wine, and I will pour wine to the upper part, to the glass actually, okay? So what will happen is that the wine will spill to the upper part, the coronal part of the glass, and it will get sucked all the way down to the bottom of the stem, but not further than the bottom of the stem, because it will get sucked out by the needle. So this is a very good, actually, there's a lot of research showing this is a very good way to clean the canal. However, it's very cumbersome. It's very difficult. You need 3 hands to do that.
Mm-hmm.
The needle is so thin that it has a tendency of getting clogged by debris. Okay, and the canal has to be wide enough, over a 35 diameter, 0.35 millimeter diameter, in order for it to actually work properly. Okay, and it takes time. You have to sit there for 5 minutes, maybe more. Just activating this kind of irrigation for each canal. Okay, so this is the negative pressure. What we're talking about with our file is the no pressure, passive pressure irrigation. And this is Professor Metzger's hands, and he came in one day showing me how he thinks he can explain to the dentist what is the SAF SAF doing. And if you fill up this pot with water and soap, nothing will happen. The burnt pot will not clean by itself. But if you add a little bit of mechanical agitation to that, okay, a little bit of mechanical agitation to that, and the combination of the two, of the chemistry of the water and the soap and the mechanical agitation, will help you to clean the pot. And this is exactly what the SAF is doing. The SAF is combining between the chemical and the mechanical. So it's a true biomechanical instrument. If you remember from our last presentation, I showed you how the surface of the root canal looks like when you look at them on a scanning electron microscope.
Right,
like very porous, like a coral reef. Okay. Now, can you imagine how they should look like if you take this coral reef, take a file, okay, like the one that prisoners use to run away from prison, and you file the face of the coral reef, or take a knife, like the blades of the rotary files do, and then you take a close look at the face of the coral, and you will see that the pores in that coral will be blocked by the chips and we call it dentinal mud, okay, smear layer or dentinal mud caused by this mechanical action. Now, when you add the chemical reaction to that and the agitation of irrigant, we've been getting very good results in studies of scanning electron microscopy. What the researchers do in this kind of study, they will treat the root canal, and then they will split it open and look inside with a scanning electron microscope to see how many open pores they see, and how many of them are closed, and how many of them have debris. Okay, this is an example for a little bit of debris here. And this is a research from Turkey again, that showed, it's international digital research, and it shows really that the SAF got really good results. If you're talking about between 90 and 75% free of debris, and we're talking about only about the apical third of the canal, which is the hardest part to clean. Okay, and this was saying curved root canal. Yes. So this article is about curved root canals, the apical part of curved root canals, which is very difficult to get proper cleaning, okay, proper irrigation in this kind of canals. And you can see that between 90 and 75% of them were free of debris versus 39% in rotary. This is what we see from the literature. Okay, and if you're talking about the smear layer, it's this dentinal mud, which is a mixture of collagen and water and calcium. Okay, paste. Then we're talking about 67 to 64% free of smear layer versus 25% in rotary files. Okay, so this combination of good shaping, touching all the walls with the file, plus irrigating all the time, is really working to clean that root canal wall. This is a new. This is from a new article. I'll just skip that. It's something a little more technical. She actually showed that you can use, if you use the SAF, you can use lower concentrations of the irrigant and still get good results. Now, this is probably the most important article that we have. This is Professor Siqueira. His lab is in Rio de Janeiro. Okay, this is me, by the way.
Ah, that's you.
Yeah, and I'm smiling because I'm in Rio de Janeiro.
Yeah.
And and I know that when this is over, I'm going to go to the beach. Now, in this research, this is about as close as we can get to the end goal of endodontics, because the end goal of endodontics is to kill the bacteria, kill the bugs. Okay, this is something you'll hear a lot from endodontics: kill the bugs in the canal. So, and what Professor Siqueira did, he's a whiz, microbiology whiz. He wrote actually a textbook that is studied all over the world about microbiology of the root canal. Okay, so and he has a lot of articles. He tried a lot of different instruments. Okay, and never found any difference between those instruments when it comes to disinfecting the root canal. Okay, you can find differences if you use 5% of hypochlorite or 3% or 1%, but you cannot find a difference if you use ProTaper, Profile, Twisted File, or Wave 1. You cannot see a difference in the actually killing of the bacteria. Okay, the bacteria don't care what brand of file the dentist is using. So, because basically they all do the same job. So, Professor Siqueira took 40 teeth. Okay, again, those teeth were with an oval cross section, and he treated half of those teeth with rotary file system, which was the BioRace system, I think. BioRace, yeah. And half of those teeth were treated with the SAF file. Okay, he used the same amount of irrigant, same concentrations of irrigant. Okay, what I didn't say is that before we treated the teeth, Professor Sikora took those teeth and put them in a soup of bacteria for 1 month. Okay, so those canals were not just packed with bacteria. The bacteria had plenty of time to form a biofilm on the canal wall. Now you must understand that biofilm is very difficult to penetrate. Okay, the bacteria on the outer layer of the biofilm actually protects the bacteria on the inner layer of the biofilm. So he tested the bioarray system, and lo and behold, he got the same results that he's always getting. 55% of the teeth were still contaminated with bacteria after treatment. Okay, you took a sample of the teeth and you find that they're contaminated with bacteria. So it's 11 patients out of 20 patients that came in your clinic with bacteria, and you left them with bacteria in the teeth. And with the SAF, he got only 4 out of 20 cases. 4 out of 20 cases that still had bacteria in the tooth. It's not perfect again, but it's really much closer to what the dentist has in mind when he's doing root canal treatment.
Good.
So this
Very good.
This is leading me to this conclusion, and I can say that now safely it's the first true chemomechanical endodontic instrument. You cannot separate the chemical effect from the mechanical effect. Those two effects, they work together, they synergize together to create a greater effect. Okay, I'm not really going to go into this. This is a C-shaped canal study. C-shaped canal, if you take an oval-shaped canal, like we've seen until now, and you just like try to hold it in your hands and bend it like a banana, okay, that's a C-shaped canal. This is how they look like in the mouth. They're very terrible teeth. A lot of Asians have C-shaped canals. It's an Asian thing.
Okay.
It's a demographic thing. And they don't have any special, it's not very important, but it's very challenging, and it's a nice playground for endodontists. And this brings me back. Okay, these are the results of this experiment about the C-shaped canals, and this brings me back to the primum non nocere, first no harm, and the minimally invasive endodontics, and why I believe that when we say minimally invasive endodontics, we are not bluffing or lying or saying something that we don't do. If you look at this tooth, treated by the pro taper, okay, and look at this part. So this part was prepared in a very effective way. He had this little part of the canal. This is the green was the original canal. Okay, let's imagine that it has bacteria in it, and you put the rotary files, and you went from a small number to a larger and larger, and you actually included all this canal in the preparation. So there are no leftover tissue here. Okay, but if you look, this is the this is already the end of the tooth. Okay, this is the outer wall of the tooth.
Okay.
And if you look at how much dentin you removed with no apparent reason, okay, this was what we call uninvolved dentin because it was not contaminated. There was no reason whatsoever to remove it, and yet you did. The dentist did remove. The dentist who performed those root canals was an American dentist named Lou Berman. He's very well known, an endodontist with years of experience in rotary files. And you can see how little dentin was left here. How thin is this wall, okay, compared to this wall or the original wall there was. But I can tolerate this. Let's say I can tolerate this. But this, not only that I didn't leave a lot of dentin here, I also did not clean the tooth. Okay, I didn't clean the tooth, and for me, minimally invasive means the I'll quote something here. Just a second. Okay, never mind. I won't quote. Minimally invasive meaning I didn't mean to do that. Okay. Minimally invasive, it means to take out as little tissue as possible, as practical, in order to complete the goals of our treatment. And in this case, I did not complete the goal of the treatment, and I removed too much dentin. If we're looking at the SAF operation, so you can see that I touched almost all the walls of the preparation, okay, in a very nice way. Here, this area was not treated very nicely.
Mm-hmm.
But I did leave the canal almost as intact, the wall, as I found it. If we're looking at the results, again, this is the percentage of area unaffected by the procedure. We're looking at 39% for the SAF compared to a ridiculous 67% for the pro taper. Okay, this is really not what the dentist has in mind when he's performing those treatments.
Right.
We're closing into the end of the presentation as I'm moving to obturation. Obturation is what we do after we prepare the canal and disinfect it. So in the best case scenario, what we have now is a slightly conical shaped preparation, space, volume, which is clean of everything. Okay, no tissue in it, no debris in it, and no bacteria. It's disinfected. And now we have to obturate it because we cannot just leave it open to the, as I said, it connects between the oral cavity and the patient's bones and the nervous system and blood vessels. So this is from, again Gustavo de Dios, 2012, Journal of Endo. And what Gustavo de Dios did here was to obturate root canals after he treated teeth with oval cross sections with the SAF and with ProTaper, and then he obturated them. And the system he used for obturation is an interesting system. It's called the Thermofill, or a core carrier system. Okay, core carrier, and it's made of plastic pin. Okay, and this plastic pin is engulfed, but what I can only describe as a condom of gutta percha. Okay, gutta percha is the material dentists use to obturate the root canals. And so you can see here, this is the plastic core, and this is the gutta percha surrounding it. Now it comes, when it's cold, you cannot really, it's not flowable or anything. It's really pretty thick. If you put your fingernail on it, you will make a scratch mark in the gutta percha. But when they put it, they preheat this core carrier, okay, and the gutta percha gets really soft. And then they put it in the canal.
Call from wireless caller.
You still there?
Okay.
That's sorry.
Good.
Call from
Good.
wireless
Then they placed it in the canal.
Okay.
So you can see here in the ProTaper group,
call from
this area was filled with debris, okay, and the gutta percha was unable to flow past that debris.
call from
Okay,
wireless
so it
caller.
stopped right here. And of course you can see the beautiful round preparation in that extremely flat oval plate. Same thing here. Okay, you see that you got debris here and debris here, and the gutta percha was unable to flow. I don't assume that the hypochlorite was able to flow here,
Right.
or anything else. Okay, so this is what the patient will be leaving the clinic with. And on X-ray, this would look amazing. You know why? Because the X-ray machine is here, stands here, and the X-ray film stands here. And when you take an X-ray from here to here, it looks like the gutta percha is perfectly covering all the root canal. But if we could take an X-ray from this side to this side, we could see that. Unfortunately, the way that Mother Nature positions the teeth in our mouth, we cannot take X-rays from this orientation. So you're looking at the SAF system, and you see something interesting. I don't know exactly what this is. Okay, this might be, remember, these are slices like a salami. Okay, so this might be a lateral canal that we just sliced through this lateral canal. But obviously, whatever this is, the SAF did not come in here. This is probably a 0.1 or even maybe even less of diameter. Okay, so the SAF did not physically go into this part. But if you don't, while you prepare it, if you don't block it with debris, okay, and you keep irrigating all the time, then your sodium hypochlorite will go in there and will clean out those walls. Okay?
Mm-hmm.
And here, also, the SAF kept the original shape of the root canal. And look at the obturation. Look how well this is obturated.
Right.
Okay? Keyhole. The last thing I want to talk about is retreatment. Retreatment. Unfortunately, you know, one of the reasons, the first thing that you learn about endodontics is that people use gutta percha. Gutta percha has been there forever to obturate, to seal the canal, for various reasons. One of them is very strange. They use gutta percha to obturate the canals because it's easily removed. Okay, you put it in the canal, and if you need to take it out, then it's easily removed. It's not cement, it's not glue, it's not anything that hardens. It stays soft. Okay, and this is an interesting reason because this is where endodontists and dentists and everybody acknowledges the fact that more times than not, you will have to eventually remove what you used for obturation because the root canal will be, the root canal treatment will fail. Okay? So otherwise, there's no reason to use gutta percha. You just put, today we have really good adhesive materials. We could just pour that in, use the light cure to cure it and to harden it, and you get very good obturation. Okay? So a lot of endodontists will tell you that they actually shouldn't be called endodontists. They should be called retreatmentologists. Because this is what they do in their clinics. While most dentists do root canal treatment, if they fail, they will send the patient for a retreatment to or they refer him to an endodontist. This is what they usually do all day. Okay. Now I will start off by saying that the SAF, being the non-rigid file that it is unable to pack into that mass of gutta percha, which is like a kind of hard Play-Doh, okay? And pull it out. It's not able to do that. It will just, if you try to insert it into it, it will just bend. But let's look here. This is an obturated tooth. You can see that the gutta percha is actually mixed with some material that makes it impenetrable to X-ray. So when you put it in the root canal, you will see a difference. Okay, when you take an X-ray, you will know that this tooth has an obturation in it. Okay, so this is by an article done here in Israel by Abramovitz. And what Abramovitz said, he took a root canal. Okay, he filled it up with gutta percha and let everything set and dry. And then he used the Pro-Taper Universal System, which is a system that is designated for removing and retreating teeth, removing the gutta percha from teeth, from treated teeth. And he used the Pro-Taper Universal System, and he took another X-ray of the tooth after what he thought was complete removal of the gutta percha, and he is using operating microscopes. He's a very well-trained endodontist, okay? And this is what he saw, okay? He saw leftovers stuck to the wall, okay? Here, mainly here, some here. Leftovers of gutta percha and sealer stuck to the wall. Now, this is something that is very difficult to remove with rotary or any kind of files because this is the inside of the curvature, okay?
Right, right.
So when you put a file here, the file wants to naturally, from the physics of it, it's a flexible file. You put it in here, and the file wants to be straight again, so it will go to this side all the time, and it will clean this side. but it will not clean this side. And this is something that endodontists and people who do endodontics, and especially people that work with operating microscopes, get to see many times, and they are unable to remove those parts. Okay? And they can actually work for half an hour just to try and fish those parts out, putting some sort of solvent to soften it, and then put hand files and curve them and try to reach those parts and clean the canal properly, because once you have a tooth that already failed one treatment, it's become an endangered tooth. You look at it and you know this tooth is trouble, and you really want to remove everything, all the old material, and re-clean it and re-disinfect it properly before you obturate it again, because you want to do a better job. Okay, so this is what he managed to do with rotary files, and by adding 2 minutes of SAF, he was able to almost clean it out completely.
Wow, that's impressive.
So this was the first step, and this is, I must say here, I never say that this SAF system saves you time. Okay, we used to say that. If you look at our video in YouTube, the first video that we have ever made, we used to say that the SAF saves time because we talked about 4 minutes per root canal. And the other systems, what we read on the literature, was between 7 to 8 minutes. So we said, hey, it saves you almost 50% of the shaping time. But and I didn't, and we used to say that until we met dentists, and the dentists would come to us and say, that's not true. It doesn't take us 10 minutes or 8 minutes to prepare a root canal. Arguing with a dentist who is a potential customer is never good. It will lead you nowhere.
Right.
You cannot tell him if you're not doing it in 8 minutes, you're doing a bad job. Right. So we kind of neglected this. Plus, if you really think about it, then when you look at the preparation of the root canal, of the entire endodontic treatment, so you're looking at an hour and a half for a molar, and during that hour and a half, you have to say hello to the patient, you have to anesthetize him, and you have to put the rubber dam, open the orifice chamber, locate the canal. You do shape the canal for 15 minutes, but this is all. 15 minutes out of this 1.5 hours. So if I'm saving 3 or 5 or 6 minutes out of this is not really a big deal.
Right, right.
We didn't see any point in arguing. However, here, and this is another experiment. This one was done by micro CT. Okay, this is the second experiment, and we didn't check this group actually. It's Frank Paquet again. He didn't check the curvature of the canal again. He checked here what happens in canals that are not round. Okay, and of course, that we see in this kind of canal using a very long sequence that is potentially endangering the tooth, because every time you put a rotary file in the tooth, you might cause some damage. Okay? Mm-hmm. In very well-trained hands, you are unable to clean all those areas from the old sealer. And if you replace all this, okay, with this, 5 minutes of SAF, and use the size 25 file to just remove the core, the mass of gutta percha, and then you go in with the SAF, follow it with the SAF for 4 minutes, then you're basically you're getting much better results, much closer to what you had in mind, and in less time and less frustration. Okay, so in this case, when I talk about this, because this is 10 minutes, but it's not over. Okay, now the dentist has to sit down with the operating microscopes and fish out those parts. Okay, try to fish out those parts here. And in 5 minutes, you get a near to perfect result with the SAF. So when I talk about retreatment, I definitely talk about saving time along with the better treatment. And clinical cases, just you can see here that the same canal that we saw in the experiment, this teardrop shape and another teardrop shape with an isthmus in the middle. and you can see that it kept it this way in the how clean it is. Let me see if there's something interesting. I can show you. This irregular part here was nicely cleaned and filled with the obturation material. This is what I talk about when I say healing, by the way. Okay, you see, this is the tooth, and this is the root canal going inside the bone. All the gray material around it is the bone. And you can see here that this almost black, dark area, okay? And this black, dark area is actually where the infection is going on. Okay, the bacteria from within the tooth are leaking outside, causing a very prominent inflammatory response, which is usually most of the time it's also painful, and the bone is receding. The bone does not want to be in contact. Doesn't want to be in this battle zone, so the bone is actually receding and dissolving here. Okay, so once you cleaned out the root canal and you disinfected all the germs, the bone is able to grow back, and you don't see as much resorption. This is from Russia, and this is the, I think I mentioned cone beam CT. Cone beam CT is like the CT that we know from hospitals, but at a resolution high enough to show root canal. And you can see the treatment. This is how it looks like in using a microscope. And this is the distal canal. These are the mesial canal. This is how it looks like after treatment. Okay, you can see how clean this is and how this is still oval. Okay, and this is how it looks like in cone beam CT. You can see that the canal is oval, and you can also see that the obturation after is oval. And you can see how little plates you have here. This is almost a 1-to-1 size, I assume. Okay, and you can see what will happen if I take a round burr and I work my way here. I would definitely damage the tooth. I will break the tooth. I will break out of the shell of the tooth.
Right.
Okay? This is the X-ray. This is how the X-ray looks like. This was taken in a slight angulation, so you're able to see the nice. It's actually a very nice picture. The nice shape of the canals. You can see that those two canals, okay, they start out as two canals, but then they separate and then they merge again into one canal. Okay. Just to show you, I think this is before treatment. This is the SAF inside the canal. See how I have it the shape of the canal?
Yep.
And this is the canal after treatment. Okay. And this is the canal after it's healed. You see that this is the lesion, periapical lesion, and now there's no sign of it. Yeah. So this is healing. This is what I'm talking about. And one thing I have to tell you, some dentists, I have this very nice article about what is success in endodontic treatment, and some dentists will advocate success as to be, if the patient is not complaining and the tooth is not breaking or falling out, this is success. And this is very, in my eyes and in many others, it's a very low way a very low place to put the bar for success, because let's say I have this patient, okay, and this is a picture of a before treatment, and you have those periapical lesions, and let's say that I treat this patient, okay, and I obturate the canal, and 2 years later I still have two very nicely obturated canals with two very nice periapical lesions. Some dentists will look at it and say that this is success. And for me, this is leaving your patient with a disease. It causes a systemic effect. If you have diabetes, then it will worsen your diabetes because you have a chronic infection. Okay, it doesn't matter if it's in your leg or at the tip of your tooth. If you have a chronic infection, this will affect your health. If this patient will have to undergo radiation therapy, then the first thing that they'll do before irradiating her will be to extract all those teeth with the periapical lesion. Okay?
Oh, wow.
Because these are contaminated. This is a source of disease, and if your patient is going under chemotherapy or radiation therapy, and their immune system is decreasing, so this might get lethal and kill them.
Right.
And since you don't have time to treat those teeth now because you have cancer, okay, they'll have to take teeth out just because somebody thought it was good enough. Okay? And for me, I think this is why implants is a battle between implants and endodontics. Implants are winning right now because endodontics is definitely better than implants. Okay? Definitely better. But if you only look at it as something that is supposed to hold the crown, and if the crown is still there and the patient can chew that this is good enough, then you will lose that battle because you're not showing how good you are. Because implants, they hold crowns very well for many years. Okay, they're easier sometimes, and in a lot of cases, they're easier to do than endodontics, and the crowns look nice for many years. So why not do an implant? So this is something I keep telling the endodontist. It's not something I thought about. It's from an article that it's called. It's by Professor Sequeira, and it talks all about the future of endodontics and where is this profession going. Okay, this is another thing. I'm pretty much done. This is all a little bit of anecdotes and stuff that can help you when you talk to dentists. Today, there is no solution for wide canals. As funny it may sound, okay, if you have a very wide canal, there is no endodontic file that is wide.
Right.
You can take a small file and try to put it in and blindly go over the walls and, just go up and down, scrape the walls, and imagine that you did something good, which is not necessarily what is happening. Okay, so there's no real solution for that. And who has wide canal? Children. The tooth is like when it erupts in the mouth. It's an empty shell. Okay, you have a really wide canal with a very empty shell. If you take a tooth that is just erupted, and kids can break their teeth very easily, easier than grown-ups because their teeth are like eggshells. Okay, and then during the years, the tooth actually evolves. It grows from the shell inwards. Okay, meaning that the root canal of the tooth is getting narrower and narrower with age until when you're probably 80, 85, you almost don't have any root canals in the tooth. Okay,
Mm-hmm.
so this is how this thing works. And a lot of kids need to undergo root canal treatment. Some of them have caries, and that's understandable. And a lot of them get trauma to their teeth. And once you fall on your teeth and you get get hit on your teeth, okay, one of the things that may happen is that the blood vessels leading to that tooth from the bone into the tooth actually break, and the tooth gets disconnected from the bloodstream, and it dies, and it changes its color, okay, because everything dissolves inside. So there are many teeth that have to undergo root canal treatment. Now this guy here, Dr. Raviv, is from Jerusalem, and he's the guy. In Israel, we have a very good health insurance, okay, and this health insurance includes insurance for, it's not a dental insurance, but everything that happens to the kids in school, if they fall and break their teeth, anything else is covered by this insurance, but they have to go to a special dentist that has the, he has a deal with the government.
Right.
So here's the guy in Jerusalem that gets all the referrals for endodontic treatment to children that has dental trauma. So he deals with wide canals all day long. Okay, he's using the 2mm version of the file. He's loving it, Okay, he has great results with I think I have some healing here. Let's see. Yeah, some great results with healing. Okay, and look how wide this canal is. Nothing
Wow.
can, nothing else that I know. Another wide.
So a great target is pediatrics dentists.
It is a great target. It is. We are actually working now on developing a file for pediatrics because children they tend to have smaller mouths, and you need a shorter file sometimes because you don't have room in the mouth. So we're working on something right now. This is from Singapore, and we got a lot of follow-ups here and healing. And I think basically this is Dr. Marty Levin. He used to be our KOL, okay, in the United States. One of the KOLs, one of the three. This guy is from Kenya. And I just get a kick out of the fact that we have a dentist in Kenya.
Oh, that's great.
So this is basically this is how I finished my presentation. And for years, dentists have been trying to put a round peg in an oval hole, and this is just not working. Okay, and the same way we teach our children to use the right shape in the right hole, this is something we should do. The SAF is not here to replace all the other files in the world, but it is definitely another tool in the dentist, in the endodontist toolbox. Okay, there are definitely cases when I think it's almost, I don't say that really, I will say that to you. I think it's malpractice not to use it. Okay, not for every case, but if you do open the orifice and you look inside and you see an oval root canal, this is a malpractice to use a round burr. Now, until 2 years ago, this is all you had. You opened your toolbox, you had one tool. Okay, you had a hammer. That's it. But since 2 years from now, since 2 years, we have this new file, and it's a great tool for irregular shaped canals. And at least for that, it's just something that is worth to have in your clinic and work with. Okay, you will see a lot of dentists using different tools for endodontics, especially the specialists. They will use the ProTaper Essex file just for the coronal shaping because it's really good at that. But then they'll use the twisted file or the raised file for the apical part because they love the way it curves. Okay, so they know what it is to use different files and mix. And I think our goal now is to make them understand that this tool is something they need to have in the clinic. For me, in the market, I don't know what the prices you were talking about with that, but here in Israel, it's very pricey. It costs a lot of money. We sell them at approximately the same price as we want to sell them in the United States, and it costs a lot of money. So immediately, being the people that we are, immediately when I speak to a dentist, I see him calculating in his head what it's going to cost him to switch from. He keeps calculating, I'm doing 3 root canals a day, and today they cost me so-and-so, and this is going to cost me like 3 times more. And I will immediately stop him and say that this is not the way to think about it. The way to think about it is that you use it as another tool. Okay, and when you have a case that you cannot do without it, you will use the SAF. Okay, so this way you keep your costs at the same area, but you still get better treatment for your patient.
Okay, very good.
I think we're done.